for all of you who don't know me, I'm Alexander Engel. I'm the director of Sydney Vital, and next to me is Chris Watt, who you know much better than I think, I hope. Anyway, so Sydney Vital is the Translational Cancer Centre at the North Shore area. We're funded by Cancer Institute New South Wales, and we're on our second year now. We've had our first year, and we've done a number of communication series, and this is our education series. We've done one in lung, one in rectal cancer, one in neuroendocrines. Lymphoma is our first non-solid tumour issue. And it goes to show that what we want to do with Sydney Vital is encompass all tumour streams and not focus on one tumour stream solely. And for this purpose of the educational meeting, we chose Nilgiris because it's confined, it's not too big, it's very good food, and you're next to each other and having a discussion and getting to know each other over some updates, in this case on lymphoma. These venues and these education series are not possible without external funding, and for this we'd very much like to thank our sponsors Sanofi, Alexia, Celgene, and of course Petnet, who have been so very generous in sponsoring our educational series for Sydney Vital. We hope to see a lot of you over the next few years, where we're going to repeat this sort of cycle of educational series. We're funded till 2019 and hope to be sort of self-supportive with a bit of funding for the 5 years following on to that. So this is, and I'll hand over to Chris to sort of introduce the program to you. But thank you very much for coming.
Yeah. Thanks everybody for coming along. For those who don't know me, I've got multiple hats, but I'm here tonight in context of being Head of Department, Director of Research at North Shore. And really what we want to do today is highlight a few of the projects that we're doing that really do fit ideally into this translational sort of mantra, because they're projects directly involving patient care, patient outcomes, new diagnostics, and some new therapies. So I think lymphoma is relevant even to folk who spend most of the time with solid tumours, because it's often a testing ground for new approaches. Lymphoma was really the first disease where immunotherapy kicked in. We've got superb outcomes in many of our patients. In fact, we can get a bit too relaxed about lymphoma because most people respond. Many are cured, many do well, but we're shifting the focus now into the difficult cases, trying to pick ahead of time who is going to relapse, who's going to be resistant. You'll hear about, for example, the double hit lymphomas. There were always a set of lymphomas that did badly. We now have a chance of picking them up early, and we'll present some of the data on how we're dealing with this. And increasingly, it's an opportunity to bring in molecular testing. You'll hear about some new platforms we've established at North Shore and are rolling out. And these have applications in breast cancer and a whole range of disorders as well. And they're really going to be very exciting, provided we get someone to pay for the tests is the next challenge. It's also a great opportunity for our young doctors and scientists to get involved. And you'll hear from several of our fellows, research fellows and registrars who are getting involved in these projects. And we want to get them encouraged, get them to see that no, you don't need to spend sort of 10 years in a research institute. You can do quality research out of your hospital with some help from the scientists and staff around you. So thank you for coming along. We've got 4 short talks. Very happy to take questions, and we'll get started. And I think the meals will just come out in between. So first off, I'd like to introduce Dr. Louise Imlay Gillespie, who's only just passed the first part of her pathology exam. So it's about time she did some work. Well done, Louise. And Louise is going to talk about outcomes, large cell lymphoma, the commonest disorder. How are we tracking? Do our outcomes match what's in the literature? Thanks very much, Louise.
All right, so I'm Louise Imlay Gillespie. I'm the Haematology Advanced Trainee at Royal North Shore Hospital, and it's a pleasure to be able to present this data to you this evening on behalf of the other investigators, which we've listed along the bottom here. This is really a retrospective review of patients treated with diffuse large B-cell lymphoma at Royal North Shore Hospital in the rituximab era. And with this data, we actually had a specific interest looking to see if we could find a c-MYC cutoff in terms of immunohistochemical staining that had prognostic significance. So just a little bit of background to start with. MYC is a proto-oncogen that can be translocated or rearranged with the other proto-oncogens such as BCL2 or BCL6 and confers a poor prognosis in diffuse large B-cell lymphoma. Usually this is picked up by means of genetic testing, and certainly in our laboratory the standard would be FISH testing for these rearrangements. The prognostic significance of MYC protein overexpression is less clear, however, and some of that is related to interlaboratory variability in terms of MYC immunohistochemistry scoring. If you review the literature, there's often c-MYC scores reported between 40 to 70% that are considered positive. And a lot of this has to do with the way MYC is interpreted and the fact that it takes pathologists to review how many cells are staining positive, as well as differences in the potential antibody clone that is being used. Given this, our primary aim in this retrospective review was to validate a MYC immunohistochemistry score that was of prognostic significance within our laboratory. We also wanted to review a few other areas with this data, including whether the MYC immunohistochemistry stain may predict for FISH rearrangements such as double-hit lymphoma. We wanted to assess whether we could improve prognostic scoring power by incorporating MYC immunohistochemistry into this. And we wanted to see if it had any significance in subgroups such as the elderly diffuse large B-cell lymphoma. So we included patients that had a diagnosis of de novo diffuse large B-cell lymphoma in the rituximab era, so January 2003 to November 2014, and who were treated with active chemoradiotherapy. We also had to ensure that there was actually a diagnostic biopsy sample at North Shore that we could assess. And patients that we excluded were those with high-grade lymphomas such as Burkitt's lymphomas or with the B-cell lymphomas that were unclassifiable. And for the initial presentation, there were patients that were relapsed or refractory coming out of the rituximab era, and we excluded those from this analysis as well. To begin with, we assessed the hematology database to identify patients, and we collected extensive data on these patients, which took quite a lot of time for this retrospective review. We generated baseline demographics on the patients, as well as disease specifics, including enough to model various IPI models, but also things like which extranodal sites were involved and where the biopsy was actually taken from. We also had a look at first and second line therapies, including the use of CNS prophylaxis and radiotherapy. And we had a look at outcomes, including imaging with staging imaging, interim imaging, and post-therapy imaging, including CT and PET scan where that was available. At the same time we were collecting all these details, the anatomical pathologists were kindly reviewing our samples and staining them for MYC and reporting them in the standard manner at that time. We then performed statistical analysis, which we'll run through the results of today. So in terms of the numbers of patients, it's just a little schema showing that we had about 350 patients that we identified, and of these, 250 had tissue that was available to us, as well as undergoing therapy actually at North Shore. The majority of patients were diffuse large B-cell, with 2/3 of them being less than 70 and 1/3 over 70 years old. There were a small number of transformed diffuse large B cells and primary CNS lymphomas, but we concentrate on the de novo diffuse large B cell in this first instance. So to review the cohort as a whole, we began with the under 70-year-old age group, certainly we wanted to validate the MYC immunohistochemical score, and we felt that if we included the older age group, there was more biases that may affect the prognostic impact of the MYC immunohistochemical score. So we began with the less than 70 age group. This is kind of the baseline demographics. So the median age was 58, with a range from 18 to 70. The majority of patients were male, and they generally had a very good ECOG score, with only a few at the higher end. The IPI was generally well distributed, although there was only a few patients with an IPI score in the high end of 4 to 5. The majority of patients, 80%, received R-CHOP chemotherapy, with a small percentage of patients having more intensive chemotherapy that generally centered around dose-adjusted EPOCH-R. The next group does include first and second line therapy, but about a quarter of patients receive CNS prophylaxis, 40% received radiotherapy, and 20% had an autologous stem cell transplant at some point in time, and only a small percentage, 3%, had an allograft. So these are the survival curves from Royal North Shore Hospital in this period of time. On the left, we have the overall survival, and on the right, the event-free survival. And generally, we have a very well-performing cohort, with the 5-year overall survival of 86% and 5-year event-free survival 77%. This was with a median follow-up time of 40 months, so quite a substantial follow-up time. And we can see the graphs kind of going out towards 10 years. We reviewed the IPI in this group, and certainly we did get the usual stratification based on the IPI. There was not much statistical difference between the low intermediate and the high intermediate and high groups, whilst it was all statistically significant. But given that, we did have a look at the dichotomous outcome of low intermediate, high intermediate, which creates a little bit more variation between the groups and had a bit more statistical power. So given that our cohort was performing as you expect and in line with the international literature, we went ahead to analyse our MYC immunohistochemistry cutoffs. With this, we reviewed the optimal performance of the MYC immunohistochemistry by X-tile, log rank testing, and ROC curves, and 70 was demonstrated to be the optimal cutoff. And you can see here that it really does separate out two clear prognostic groups. And on multivariate analysis, this and the IPI both remain independently significant. We reviewed the clinical cohorts to make sure that they were well matched, and certainly in terms of age, sex, IPI scores, they are well matched. The only difference was between the intensity of therapy, with those patients in the MYC high MYC positive score receiving a bit more intensive chemotherapy, which just touched on statistically significant. We went on to look at whether we could add MYC in for composite scores to attain greater prognostic power. And certainly we looked at things like the BCL2, the BCL6, and even the Ki67. MYC and BCL2 kind of goes into your Hens or Choi type of algorithm for the cell of origin. And given this, I've put up this graph. This is significant, and with multivariate analysis, the MYC and the BCL2 positive group does remain independently significant beyond IPI. But I think what's potentially more interesting about this graph is the very top line, which is very faint, but that's your BCL2 negative, MYC negative group, with an overall survival that's really remaining good to 100%. That's potentially a very good performing group and shouldn't be forgotten whilst we're talking about the poor prognostic markers. We wanted better prognostic modelling, however, And based on hazard ratios, we found that a positive MIC had an odds ratio of around 4.5, as did the high intermediate IPI, which is a score of 3 on the IPI scoring, and they were similar odds ratios. Well, the high IPI, which is a score of 4 or 5, has an odds ratio of around 7. Given that, we attributed different points, so 1 point to the MIC and 1 point to the high IPI, and high intermediate IPI, and 2 points to the high IPI to generate a total score out of 3. And using this, we got very good stratification of the cohort. We only had one patient who had a score of 3, but they did live up to the poor expectation of them, and they did live less than a year with their diffuse large B cell. The 5-year overall survivals are quite strikingly different for these patients as well, which you can see here on the left. So a score of 0 with a 5-year overall survival of 94% compared to 78% compared to 45%. And that was highly statistically significant. We thought that MIC might correlate well with predicting a potential double hit lymphoma on FISH, but when we reviewed this, that wasn't the case in our data, but that may be because of the small number of double hits that were represented within this cohort. So just a quick look at the elderly diffuse large B-cell lymphoma cohort, so those that were over 70, just as a slightly different point of view. So these patients had a median age of 79 and were aged up to 88, receiving active therapy. They generally had a poor performance status compared to our younger cohort, but they were evenly spread through the IPI scores. The majority of them received R-CHOP chemotherapy, but some of the ones in that younger, just turned 70 group did receive some more intensive chemotherapy, and one did have an autologous stem cell transplant. This is the survival curves on the top is the patients that were less than 70, so the cohort we were just looking at for comparison, compared to those that were over 70. And whilst this isn't statistically significant, you can see that there is an inferior outcome for these elderly patients. When we applied validated MIC immunohistochemistry to these patients, however, there was no difference in survival, and on the review of various cutoffs and on the ROC curve, there was no point at which MIC immunohistochemistry was prognostically significant in this elderly cohort over 70. What I did find interesting was that beyond IPI, the other nice curves that stratify these elderly patients remained that of ECOG. And one might argue that in elderly, perhaps the ECOG does remain one of the better predictors of how these patients perform. So overall, we felt that MIC immunohistochemistry is a predictor of outcome in de novo diffuse large B-cell in those less than 70 years of age, and this could be utilised with other validated prognostic scores for improved power, but it wasn't a predictor of rearrangement on FISH. We feel the MIC immunohistochemistry should be locally validated, or if you're intending on using it in a prognostic manner, perhaps it should be interpreted, well, it should be sent to be performed to a lab that has had validation, given the variety that is described within the literature. And in our hands, MIC immunohistochemistry is not predictive of outcome in elderly diffuse large B-cell lymphoma. We did collect large amount of data on these patients, and given that we are planning further correlations, including nanostring technology, which Dr. Kibbe will talk to us about a little bit further, we are currently scoring some of our PETs, which I know Dr. Griddens might touch on tonight, and we're going to assess the role of MIC immunohistochemistry in the other subgroups that we've collected information on.
Louise, we've got time for a couple of questions, and I just mentioned about 10 years ago we did this exercise and looking at the over 70 spines with large cell And what struck me is exactly what you've seen there is that the ones that got treated had actually very good outcomes. It's not as good as the less than 70, but for the ones you get to treatment, it was good. So I'd be happy to make any comments or questions from the board.
It was a fabulous presentation. You did an extraordinary job. I don't think there'd be many sites in Australia that could do that, so you should be congratulated. Did you find differences between males and females, for instance, and also BCL2 positivity alone? Was that an indicator? Was there any separation?
So BCL2 positive, MIC negative, was statistically significant, but on multivariate analysis didn't fall out independently. In terms of male to female in the less than 70-year age group, there was no difference between those cohorts. I'm having to assess that in the elderly age group yet.
Did you find any variability between the pathologist who was reporting the immunohistochemistry staining percentages? Was there much variability?
There wasn't much variability. They did both report the samples independently, and then it was correlated. And generally, between the two pathologists who were reporting, they were in agreement. We should do some analysis though to see if to prove that statistically as well. Thanks, Jonathan.
Can I just get my last comment from men trawling through the data? It's wealth data, must be published, at least locally. And I just would love to be able to say to my young patient below the age of 70 coming into Concord, well, we've done a study of more than 300 patients at our institution, and I can tell you, the average 5-year survival is 86%.
Yeah.
That's an absolute credit to every hematologist I'm sure will be able to have such a figure. So I think it was important to get the kappa coefficients for water components.
Yeah.
Because certainly once you must go and write this up, once you submit that, the review will ask for that. I think the next question the reviewer is going to ask too is, despite its limitations for the Hans algorithm, what's the non-GCB, GCB phenotype distribution in your upper 70s and in your over 70s, and how their outcomes work. And I think it's just fantastic work, and we're love to have known that you were actually doing this work as we're putting together the data for the over 70-year-olds over the last decade for 3 different hospitals, and we only got 110 patients.
We kind of specialise in treating the elderly at North Shore because of our demographics. We have an extraordinary number of very fit elderly who are worth a go. So, anytime we're putting together a series, please give us a call. If there's no other questions, Mark,
Did bulky disease fall out as in the univariate or multivariate analysis?
I don't think we had bulk as a separate factor that we looked at. Radiotherapy was provided for bulk generally, so that's, but radiotherapy didn't fall out separately as a predictor. And there was another question?
Age-adjusted IPI, that helped with it?
Yeah, so all of the IPI models were significant. We just ended up picking one to run with.
Chris, coming from a different area, the introduction of PET in 2010 means that this is a patient cohort that might have got PET early or probably now definitely get PET. Do you think that's changed anything in the way they're managed?
I'm not sure it makes a lot of difference. It makes a difference in the initial staging of the thing, but most of them would have still had the stock number of treatments, and we're not yet with this disease in the position outside of trials where we're modifying treatment based on PET. So it's just the staging effect.
It was interesting though, seeing kind of going from 2003 up to 2014, all the patients going from interim CT, chest abdo-pelvises, slowly across to PETs, where now a lot of patients don't have both, they just have the PET, particularly interim and post-therapy, so there has been a change.
you.